Hello, my name's Roanna Lobo, and I'm a researcher in the School of Public Health at Curtin University. This presentation builds on the previous ones and relates to the Increasing Aboriginal People's Use of Services that Reduce Harms from Illicit Drugs project. You've heard about the role of the Aboriginal Advisory Group and some insights and reflections on our experiences of using a co-design approach. In this presentation, I'm going to share some key themes arising from the people we interviewed and the intervention areas arising from the research. As you've heard, this was an exploratory research grant and there were 13 co-design partner organisations. The organisations have given very generously of their time, and the research really would not have been possible without this level of participation. And we had representatives from Aboriginal community-controlled health organisations, the Needle and Syringe Programme Services in Perth and a regional area, peak bodies and the WA Department of Health, as well as research institutes and groups. With 7 objectives, the study aimed to provide insights into Aboriginal consumers' understanding of safer injecting drug use, understanding the services and support required by specific groups, understanding the needs and activities of secondary exchange providers or those who supply equipment to other people, looking at the common and unique features of metropolitan and regional needle and syringe programs or NSPs, the ways in which Aboriginal people access and engage with NSPs, the attitudes and concerns of key informants within Aboriginal communities, and finally to co-design recommendations for interventions to enhance the delivery of client-centred NSP services. When these were defined, we didn't have our Aboriginal advisory group in place. However, we did have the peak body, Aboriginal Health Council of WA, and all of our peer-based NSP community organisations and other NSP services. One of the things that arose from the interviews was the variety of language used for drugs or injecting equipment, and this information is going to be useful for health promotion and education information that we might prepare for this group. All of this information will be in a full report on the study coming out soon. So the key themes from the interviews were pretty similar between consumers, staff, particularly. Key informants gave us different perspectives about attitudes and concerns in the community. And you can see that the ones highlighted are really some of the different ones between staff and consumers. But the most prevalent theme would have been shame, and this occurred in every single interview that we conducted. Other common themes were perceptions of being judged, racism, feeling discriminated against, perhaps from treatment from other services. Location and opening hours was sometimes a barrier, depending on where the service was located, and sometimes it was an enabler for those located close to train stations, etc. There were fears of carrying equipment and being stopped by police or Transperth officials. Some people just didn't come to services because they relied on others to supply them with their equipment. For some, it was the effects of drugs and they were unable to plan their needs in advance and therefore perhaps did not have equipment available when they needed it and services were closed. For others, it was not seeing Aboriginal people within services and the cultural security that afforded. And for some, it was just a lack of awareness or knowledge of services. Key informants told us about the lack of holistic approach and funding issues around providing enough funding to support Aboriginal community engagement. So there are some quotes here from the various interviewees, and as you can see, there's one about shame, and the source of shame really varied from internalised shame to culture-related shame or shame perceived from others. One consumer said, a lot of them are ashamed. They're ashamed of people knowing their business. They're ashamed because they're Aboriginal, and Aboriginal people have a lot of shameness in them. So this is a big issue that services cannot really address on their own and is going to require a universal effort involving communities. The lack of anonymity was a particular concern, being seen by family members and perhaps that going through the bush grapevine, as they called it. If a consumer didn't want to have more than one needle on them at a time, the need to get multiple needles was most likely not very high. And one consumer who was street present explained that he felt it wasn't safe to have equipment on him, used or otherwise. Because we're on the streets and sometimes police officers, I hear that they actually are charging people. They charge people if they have them. Consumers also commonly discussed having peers who relied on others to get their equipment. And as you saw in the previous presentation, there was a large number of people who did this, of those that we interviewed. So motivators and facilitators for using NSPs, again, there was a lot of similarity between staff and consumers. And this reflects, I think, the real knowledge that staff and the relationships that staff build with consumers, that they do understand their contexts and their needs. But some key differences that came out of consumers that were really interesting were that family members encouraged them to come, that it was a free service, and that they came because they received education about injecting and because they just actually wanted to use sterile equipment. Other common themes included accessibility of services, being able to take a large quantity if needed, the discrete location, having other incentives there like food or water, care packs, no judgment with staff and a real rapport with staff, and feelings of confidentiality. Again, there are some themes here looking at incentives. I like how there's always cold water and fresh fruit, and that even if I'm having trouble paying for things, I can just exchange. So I don't have to pay $10 for 3 or 5. I can go in and get freshies. It's healthy for you and it makes you feel better in yourself and that you're being clean. I'm a user and I like to use it in a clean way and a healthy way. You know what I mean? There were some differences between regional and remote consumers' experiences. Overall, regional staff mentioned barriers and enablers that were similar, but there were some differences. Often people, when consumers were asked if they travelled regionally and how they obtained sterile equipment, of 25 consumers interviewed, 10 said they occasionally or frequently travelled regionally. And many participants who travelled commented that they stocked up on sterile equipment and also gear or drugs before heading regional, and others mentioned that they didn't use in their home regions out of respect. My family, they don't allow it. They all know I use drugs and everything, but I don't like them seeing me on it, said one consumer. Access to injecting equipment from vending machines was mentioned as a positive in the country. And the lack of anonymity involved in accessing NSPs regionally came up very strongly. Many consumers mentioned going out of their way to get equipment from a town where they were less likely to be recognised, and staff had also noticed this. Multiple staff also commented that due to the diversity of each region, there was no one-size-fits-all, and NSPs suited community needs in their region. And long distances to travel to an NSP was mentioned as a barrier to access. The distance between NSP sites through regional areas, particularly and especially for Aboriginal consumers, can be an access barrier. If you're living in a community that's your closest NSP could be up to 2 hours away, that's quite a distance. And that's assuming that you've got a ride into town or you've got a car that you can use to actually come in and get what you need, said one regional staff member. Another area we explored was secondary supply, or the distribution of injecting equipment obtained from NSP services by an injecting drug user to other injecting drug users. And 68% of those we interviewed identified as being a secondary supplier. Relying on a nominated member of the community to collect equipment for multiple people was also common in the regions. But it is specifically legislated against in all states and territories, despite it being an extremely common practice. One staff member said, "It's quite a common thing. Why would 3 of you come down if you lived in the same house when one of you can come down?" Alternatively, there was a noticed trend of consumers using drugs whilst in town only, and one regional staff member said, "Generally what will happen is a group of people, maybe from the community, people come into town, get whatever they're injecting and come to the NSP and get their equipment, and then they'll use it in town over maybe a week. They'll use every day for a week and then they'll go back out to community." When asked how consumers go about doing secondary supply, it seemed it was mostly done in an informal fashion. A common theme was people just knew who to ask for when it came to who was distributing sterile equipment. and drug dealers were also often a source of sterile equipment. In terms of staff and key informant attitudes, overwhelmingly, staff saw secondary supply as a positive in increasing needle coverage. I think it's awesome when people are happy to get equipment for other people, especially if those other people aren't willing to come to the service themselves, because it doesn't mean that people still have access. It does mean that people still have access to sterile injecting equipment, said one staff member. There were, of course, some negatives discussed, such as the potential for consumers to on-sell equipment and supplying larger quantities, leading to a lower return rate on used equipment. Staff felt they had to balance out their obligations to the law and ensuring consumers had access to sterile equipment. From Metro NSPs, a staff member said, often people will want more equipment than they bring back. They tell us it's because they want to help out other people. We always explain to them that's not really lawful, and what they should do is to get them to come here, because I wouldn't want them to get into trouble themselves. We looked at risk mitigation in terms of safe injecting practices, and reusing your own equipment was extremely common, and consumers mentioned a number of mitigating practices. Yes, I reuse. Yes, it sucks. The most I use is one needle. For one needle is 3 times. Sharing equipment was also very common, and it was generally done only with people the consumer trusted. I've never done it with someone I don't know. You know what I mean? So reasons for reusing often included needing a sterile syringe when NSPs were closed, impatience to source clean syringes to use the drug, and other barriers to NSP access already mentioned. Strategies people used to manage risk were cleaning used equipment, having a limit on the number of times a syringe would be reused, or reusing a syringe that had not been used repeatedly. It depends on if you do know most people that will have fresh darts on them and whatnot. If not, you just go back towards your old one, but I don't use my old one more than twice. In our sample, 28% of consumers reported sharing equipment or sharing receptive equipment or someone using their equipment, but they only shared with someone they knew well, such as an intimate partner, family member, or friend. If it has to be sharing, it would have to be my girls or a brother I really do know very close, and that would be from jail, said one consumer. And the reasons for sharing were not extensively explored, but included not having enough sterile needles available, not knowing where to get sterile needles, and having no access to sterile equipment in prison. Sharing is also sharing being part of the injecting behaviour they'd been taught, and trusting the people they shared equipment with. As a result of all the data that we collected, and it really was very rich, we've identified 5 intervention areas. And one of these is community education and raising awareness of harm reduction in services available. There are myths about harm reduction and the role of NSPs as promoting drug use, when of course they are for minimising harm and minimising harms associated with drug use. Another was to look at establishing referral pathways to meet complex needs and developing a holistic, consumer-centric, integrated service model. A third one was to pilot a peer referral program where we would train consumers to encourage their injecting peers to come into services and engage in bloodborne virus testing. A fourth was to look at availability of services and whether more outreach locations could be considered. And finally, looking at the cultural security of services and looking at cultural awareness training for staff and certification of services against a standard. Large number of people were involved in this study, and I'd like to thank all of them, particularly the NSP staff, volunteers, consumers, and key informants who participated in the research. If you'd like any more information, do feel free to contact me at Curtin University. Many thanks.